contact tracing here in the Philippines. And our speakers for today will educate us what really is contact tracing, determine the importance of contact tracing during epidemics and outbreaks, specify the issues and challenges in contact tracing, discuss the status of contact tracing here in the Philippines, particularly value and determine the value of testing of contact tracing here in the country, and what are the future steps for the improvement of contact tracing here in the Philippines. So we invited two speakers, one from the WHO and another one from the Department of Health, to educate us in the value of contact tracing, particularly in this pandemic here in our country. I'll give you the CV first of the first speaker, and then I'll introduce the second speaker later after the first speaker finishes her talk. However, for the house rules for this webinar, we would like everybody in the who are participating here in the webinar to please mute your mics, so we won't be hearing any sounds from you. And for your questions, please type your questions in the Zoom and at the PCP Facebook Live page, and we will be answering your questions after the second speaker. So for our first speaker for today, she worked in various capacities with the World Health Organizations in the Western Pacific region, and she's also the coordinator of the Essential Medicines and Health Technology Division of Health Systems WHO Regional Office for the Western Pacific. She served as an acting director, Division of Health Systems in 2019, and is currently in the WHO country office in the Philippines as acting WHO representative to support the response to COVID-19. She's the group coordinator of Health Systems WHO country office in Hanoi, Vietnam, and is the technical officer Pharmaceuticals WHO office in Hanoi, Vietnam, and the WHO country office in the Philippines. So fellow doctors and healthcare workers, please welcome Dr. Socorro Escalante from the WHO.
So thank you so much, Dr. Eliva, and good morning to everyone. Good morning to the esteemed colleagues of the Philippine College of Physicians. We thank the PCP for inviting WHO to discuss this very important issue on contact tracing. And I am joined by my colleagues, Dr. John Juliard-Go, who is the technical officer also at the National Country Office here in the Philippines, as well as Dr. Albert Domingo. So shall I start, Dr. Oliva, with my presentation?
Yes, ma'am, please.
So I hope everyone sees my presentation. Is it clear on the screen, Dr. Raymond?
Yes, ma'am. Can you please PowerPoint presentation, ma'am? A slideshow po, ma'am.
Yeah, it's on slideshow. So sorry, give me a second. Hindi ko siya ma-slide. Naka-slideshow pero hindi daw nila nakikita.
Excuse me, nakikita na po yung yung slideshow?
Hindi pa rin, sir.
Hindi pa. Magsalita si sir. Visible na po.
Sir, naka-presentation slide ka.
Okay. Yun nakikita nila. Yes.
Okay na, sir.
Ayan, okay.
Thank you so much, and I apologize for the delay. So I'm going to take this into the context of breaking the change of transmission for COVID-19. And I will be presenting the overview, and then a little bit about how do we describe the chain of transmission for this infection, and then we will tackle the steps in contact tracing. And I would like to give a little bit on special focus on healthcare worker infections. So to start with the overview, I just want to give a recap of what is the situation of COVID-19 in all the regions. And when I say regions, I'm talking about the WHO regional offices. So we have the Americas, the European region, we have the Eastern Mediterranean, the Southeast Asia region. Our region is the Western Pacific, and we have the African region. So if you are going to look at this slide, you would see in the first stages of the outbreak that the pink epicurve there, this is mostly the cases that were in China. So China then was the epicenter of this outbreak. And then we see that the outbreak was contained in China, and then it moved to the rest of the world. So the epicenter now has become the Americas and also parts of Europe. And you would see also the green. So the orange one would be the American region. Then the yellow one is the European region. Then we have the Eastern Mediterranean in red. The violet is the Southeast Asia region, and the pink one is the Western Pacific. So you would see that as compared to many regions in the world, that the Western Pacific cases are relatively a lot less than the cases that we now see in the Americas and in the European region. And this is a more detailed view of the situation in the Western Pacific region. Again, this is trying to show us again that in the first few months or weeks of the outbreak, the epicenter is China. So that's the blue one. And I will be explaining a little bit later in the context of the contact tracing, how China was successful in terms of containing the outbreak. And then the early countries where transmission happened includes South Korea, and this is the yellow one there. But you would see as well that they had a peak around the first weeks of March. However, they were able to contain the outbreak or suppress the transmission from the second week of March up to now. And then you would see the other waves of infection that are increasing, and that's now the Singapore, Malaysia, Japan, and the Philippines. Philippines is the green bar there, and you would see that we are now among the highest in terms of the number of cases in the Western Pacific region. And this is a very specific epi curve for the Philippines. So this is a WHO data that we try. It's actually a government data, but we try to do an analysis every day. And you would see that continuous new infections are reported every day. And although the numbers are relatively stable at around 200 to 250-ish, this is still to us not a good indication because we are not reducing the number of infections that are reported per day. And if we are going to look at how the outbreak has spread across the country, we know very well that the first few cases started in Cebu and then in Manila. We had a lockdown on the 16th of March to prevent the infection out of Manila. But still, you would see that the different graph, how the transmission across the different regions of the country has progressed. And we would see now that as of 18 May, almost all the regions in the country have COVID-19 cases. And there are already around 61 provinces which have COVID-19 confirmed positive cases. So how do we break the chain of transmission of infection in the context of all the shifts of the infections from one country to another and from region to another? And before going into the specifics of contact tracing, I would just want to show what we call the COVID-19 transmission terminology, and I'm sure many of you are aware of this. So we look at the outbreak in different stages. Actually, there is a stage 0 that is not presented in this slide. But stage 0 is when infections are occurring in one country but not yet present in our country of jurisdiction. So stage 1 starts when cases become imported. So like what we had in the early January, that we had cases from China coming to the Philippines. And usually the response that we are going to put is to contain this infection. And then if we are not able to contain the imported cases, then what will happen is that the infection is going to be transmitted. So that is now what we call a localized community transmission, and that is stage 2. That is the blue box. And the stage 2 will now compose of clusters. So clusters meaning that you could still connect one person that is infected to an index case. That is what we call the epidemiological link. So we could still connect the chain of transmission from one person to another. However, if we are not able to contain the cluster, the stage will now progress into what we call the large-scale community transmission. And as you would see, that the clusters will not only be limited to 1 or 2 clusters, but many, many clusters. And there will be individuals who are now going to be lost to contact. And if we lose these individuals to contact, they are the ones that would actually facilitate the transmission into the community. And this is now a very worrying stage, because this is where our health systems is going to be challenged in terms of their capacity of taking care of the infected individuals, as well as potentially excess death if our health systems cannot cope up. So what is the strategy of WHO that we are always trying to push to countries as much as possible? We are going to ensure that the country will continue to be in stage 2, but we need also to prepare our health systems to cope up with large-scale community transmission. So this is a very basic point that we all need to put in mind as a basis of the principle of contact tracing. And just to give you a very particular example how Korea is doing its contact tracing. So here they try to identify the index cases and the people who are infected and connected to that index case, and they call this as clusters. So for example, in that encircled with blue, that is the first cluster that they have identified from an index case, and then from that cluster, it infected individuals from the community center after 3 weeks, and then it spread to the church after 3 weeks, and so on and so forth. So the way that Korea is tracking the spread of the infection and identifying these clusters is through a very rigorous contact tracing, which is our topic for today. So what are the steps in contact tracing? Again, before I go to the steps of the contact tracing, we also advise how do we do contact tracing in the different epidemiological scenarios that I have explained in the previous slides. If there are no cases, we need to start having to prepare a well-trained contact tracing workers, and that they should be on standby and ready to respond in case there is a first case that will come into the country. And then during the stage 2, where we call there are sporadic cases or imported cases, we need to undertake very exhaustive contact tracing so that we could rapidly suppress the transmission. And once we are able to identify and contact trace the contacts, that we are going to be able to isolate and quarantine them immediately. Third, on the clusters, on the stage 2, contact tracing also is essential. Again, the same for suppressing the transmission and reducing the transmission within the clusters. During community transmission, it is now very challenging and very difficult to track the transmission chains. However, we should still continue to carry out contact tracing as much as possible. And we would now need to focus on household contacts, on healthcare workers, on high-risk and closed settings such as dormitories and jails and other institutions such as long-term care homes, as well as vulnerable contacts. And we need to maintain a very strong contact tracing capacity, also in areas with small clusters of cases. So again, when the countries have passed the peak of the infection, we would advise that we will continue to undertake contact tracing so as to monitor potential resurgence of the outbreak. So what is contact tracing? So it's defined as the process of identifying, assessing, and managing people who have been exposed to a disease. And particularly the purpose, again, is to prevent onward transmission. So this is an essential public health tool for controlling infectious disease outbreaks, again, by breaking the chains of transmission, and it will systematically stop or interrupt transmission from one person to another. So specifically for COVID-19, this requires identifying persons who may have been exposed to COVID-19 and following them up daily for 14 days from the last period of exposure. So it's a little bit complex, but WHO and the Department of Health has tried to break it down into 3 simple steps. And the first step is to identify, meaning to identify the case. And what we mean by a case, it means a suspected individual, a probable individual, and a confirmed individual. These are all the cases these individuals are all considered cases. And we will explain a little bit later what do we mean by suspect, probable, and confirmed. Once we identify, we are now going to do the contact tracing itself. And contact tracing is not, takes 2 forms. One is listing the avenues, meaning the places that have been visited by the individual who is a case, and also identifying the close contacts. And we are also going to define what is a close contact later on. Once we have listed the avenues and we have identified the contacts, we need to take action immediately. And the actions that we are going to undertake would be: one is to isolate the case, two is to quarantine the contact, and three is to announce to the public the places where the confirmed or suspect or probable cases have been to. And if this case has been in attendance, for example, in a meeting where other people have attended, particularly we are very much monitoring social gatherings where there are more than 7 people that is undertaken in closed settings with very poor ventilation as high-risk places. So we focus our contact tracing on those kinds of meetings or social gatherings that have happened in the past 14 days. So basically, again, 3 simple steps. One is identify the case. Second, list the avenues and the contacts. Third, take action immediately as appropriate. So let's now go to the first step, which is identifying the case. There are a lot of definitions on suspect case, but WHO has come up with 3 types of suspect cases, but countries have also adapted and contextualized the definitions in their own context. So a suspect is a person who is presenting with any of the following conditions. One is that all severe acute respiratory infection, that is SARI, cases where no other etiology fully explains the clinical presentation. Second, we are also looking into influenza-like illness cases with any one of the following, again with no other etiology that fully explains the clinical presentation, plus a travel history or a residence in an area where reported local transmission is seen. And then someone with an ILI or influenza-like illness with contact to a confirmed or probable case of COVID-19 in the 2 days prior to the onset of the illness or prior to the onset of symptoms of the probable or confirmed cases until the time that the probable or confirmed case became negative on repeat testing. So just to simplify these definitions, what we are now trying to advocate to physicians and to health workers is that anyone who comes to the emergency room or for consultation with signs and symptoms of fever, cough, shortness of breath could be considered as a suspect for COVID-19. Particularly now that we are in a localized transmission, so we need to put a high index of suspicion in terms of the cases that are coming and presenting to the hospitals and to the clinics. So, particularly also, again, for individuals who have fever or cough or shortness of breath, and focusing on patients who are more than 60 years old and above, patients who have comorbidities, and assessed as having a high-risk pregnancy and health workers. So these are also the individuals that are vulnerable to COVID-19. A probable case, on the other hand, is a suspect case who fulfills any one of the following. One is a suspect case from whom testing for COVID-19 is inconclusive, or a suspect case who tested positive for COVID-19, but whose test was not conducted in a national or subnational reference laboratory or officially accredited laboratory for COVID-19 confirmatory testing. This is very important, and that is why all the national laboratories and the subnational laboratories are being evaluated by our ITM and the WHO to ensure that the appropriate quality assurance and external quality assurance for laboratories is being adhered to in the testing of COVID-19 suspect cases. And of course, a confirmed case is any individual, irrespective of presence or absence of clinical signs and symptoms, who was laboratory confirmed for COVID-19 in a test that is conducted at the National Reference Laboratory or a subnational laboratory and or a DOH certified laboratory testing facility. So these are the definitions of cases. Again, cases would be a suspect, a probable, and a confirmed case. Why this is very important to discuss. In the context of the Philippines, in the very early part of the outbreak, the system, meaning the health system, was only starting to undertake contact tracing once an individual is laboratory confirmed for COVID-19. However, with the not so strong laboratory capacity, as well as delays in transporting samples, as well as in the turnaround time for tests, as well as issues on data transfer from one hospital to the Epidemiology Bureau and others, we have seen that the delay from the time that the suspect goes to the hospital up to the time that it is contact traced is around 13 days. So by that time, we have already spread the infection to many people, and that's really very, very late. So we have advised the Department of Health to start the contact tracing as soon as the individual goes to the hospital and is considered a suspect case. And the hospitals are requested under the disease notification mandate that all suspect cases should be reported to public health authorities, i.e., the city, provincial, or the regional epidemiology bureaus or your city health offices, so that right away the contact tracing can be started. And then once the suspect, the probable and confirmed cases are identified, we are now going to list the avenues and the contacts of those cases. So what do we mean by listing the avenues? So we are going to ask the case, suspect, probable, or confirmed case on the list of the activities and the settings and places that they have visited or social gatherings that they have attended in the past 14 days. Why is this very important? Because if that infection, if that individual, for instance, has had that infection from a market or a grocery, and transmission is ongoing there, we need to be able to identify other individuals who are in that setting. And then our action would then be to announce to the public or even to ask the owner of that supermarket to restrict or close until such a time that we would ensure that the infections are not anymore occurring. So it's very important to list all these activities and settings and places that have been visited. And then if we are attending social gatherings, we try to, as much as possible, list those who have been with them in those events. And meaning, however, that if you have, for example, 100 individuals, we might not be able to list all of those individuals. But we need to identify who are the close contacts. And a close contact is identified as someone, is defined as someone who is within 1 meter to a case and within 15 and have had a conversation in a span of 15 minutes. That is what we call a close contact. So there needs to be a lot of there needs to be a thorough interview with the suspect case in order for us to be able to identify who are the close contacts. And then we also need to list all others who have been in contact with them, may not be in those events, but this may be like co-workers or family members or friends whom they have met since 2 days before the onset of symptoms and within the past 14 days. So why are we emphasizing on 2 days before the onset of symptoms? Because there have been evidence that actually transmission could happen pre-symptomatic at the period of before the symptoms will occur, and that's what we call the pre-symptomatic stage. And then just again to go back to what is a close contact. So a close contact is anyone with the following exposures to a COVID-19 case from 2 days before to 14 days after the case's onset of illness, Again, primarily, it's being within 1 meter of a COVID-19 case for more than 15 minutes, a direct physical contact with a COVID-19 case, individuals who are providing direct care for patients with COVID-19 disease without using proper personal protective equipment, and other definitions as indicated by local risks assessment. But for WHO, we are emphasizing the first definition of a first contact that needs to be taken into consideration always in identifying who are the close contacts. And then the third step is now taking action immediately. So there, in our experience here, doing the contact tracing here in the country, there has been a lot of confusion. Who are we going to quarantine and who are we going to isolate? So just to make it clearer, the cases will be isolated. The contacts will be quarantined. So a suspect case, a probable or a confirmed case, once they are identified and known, will be isolated for 14 days. The way that it is done here in the Philippines is that they are isolated at home if possible, and there is a criteria that the government has put, and that criteria is having a one room and a separate bath and toilet. However, if that is not available, then the individuals are advised or taken into community isolation centers if they are not admitted in the hospitals. And in the isolation centers, they are going to be monitored for 14 days. Our health workers are monitoring them 2 times a day in terms of their signs and symptoms. On the other hand, the close contacts will be quarantined. Also, if possible, at home, we call it the home quarantine. But if it's not possible, then they are going to be taken into community quarantine centers. And in the same way, their health condition is going to be monitored. And if they are going to be having signs and symptoms, they now become suspect cases. So sometimes there is a little bit of a confusion here. But when a contact becomes symptomatic, that contact becomes a suspect case. So it's like a kind of a cycle. And then again, another action is, I'm just repeating myself, that we need to advise the public to avoid those places and settings and avenues where infected individuals may have been. And as much as possible, if we monitor that the infections continue to occur, we need to close those places. And I'm going to give you a very good example from South Korea. I think it happened around 3 weeks ago when they identified a case who is a 29-year-old male, and they tried to investigate which settings or places has he been to. And he identified a karaoke bar, and then the authorities in Korea investigated, and there is ongoing cluster of transmission in some of those karaoke bar. So the action that was undertaken by the government was to close all the karaoke bars. So these are some of the very practical public health interventions that we could do to break the chain of transmission. But again, we will not be able to undertake these very simple public health interventions if we do not have a very good contact tracing mechanisms. And then again, of course, we need to follow up all contacts, and we also need to provide information to the contacts in order about COVID-19 and how they could prevent further transmission of the disease to others. So, however, contact tracing is not that simple because it has a lot of dimensions involving, for example, who will be doing the contact tracing? Do we have the capacity? How will the community be engaged? Are they going to support the quarantine and the isolation interventions? Because these are all very sensitive to the individual and their families. So WHO is also encouraging the government to have a system or an environment that will enable contact tracing. And first and foremost, we need to engage communities that they need to understand about the disease, how to protect individuals and their communities, and how to suppress the transmission of infection. It's very important for us to be able to educate that suppressing a transmission would take very minimal interventions like social distancing, hand hygiene, and cough etiquette, for example. And our aim in engaging the communities is that for individuals to agree to the intervention of isolation and quarantine, as well as to daily monitoring of their conditions. The second enabling factor would be communication about contact tracing. We need to communicate that contact tracing is a part of the overall public health intervention to cut or to suppress COVID-19 transmission. And I think I'm also missing one thing here. When we say contact tracing, it is about, at the end of the day, reducing the infections that are occurring. And when we are going to be able to reduce the infections that occur, we are able to ensure that our health systems will not be overburdened by the cases. And therefore, by that, we are going to be able to reduce the number of excess deaths. So many of you, and there has been a lot of conversation about flattening the curve in the past few weeks, and maybe I'll just touch here how we are trying to communicate the flattening the curve, maybe not very, very clear, but contact tracing is a part of that public health intervention to flatten the curve. So basically, flattening the curve is that in the early stages of the outbreak, and especially for infections like COVID-19, which has a very high transmissibility, there will be a peak of the curve, surge of infections. And if we are not going to be able to suppress that infection, then our health systems will crumble. They will not be able to cover all the number of people that will be going to the hospitals and our clinics. When we say we need to flatten that curve, we mean that we are going to institute public health interventions such as contact tracing in order for us to break the chain of transmission and lessen or suppress the infections to a certain extent that our health systems will be able to cope up and prevent excess death until such a time that the pharmaceutical interventions such as vaccine and medicines will be available. So communicating this very basic concept of what is flattening the curve and understanding why contact tracing is important to the flattening of the curve is very important for public health individuals as well as for clinicians and health workers like us. So in terms of our recommendations, and just summarizing this whole of contact tracing discussion before I go to the specific, special topic, we need to start contact tracing at the first instance that a suspect case is identified. We should not wait until laboratory results are confirmed. We need to inform the public health authority immediately, and that is again our responsibility as clinicians and the hospital under the mandate of disease notification. And the hospital management also should be informed to seal possible avenues of exposure of healthcare workers and other patients in the hospital. So we need to conduct rigorous contact tracing for all cases at the point of patient encounter. And again, we need to collaborate with public health authorities and the communities. And before closing, I would like to have a special focus on healthcare worker infections because I felt that this is also an opportunity for us to be able to communicate and to potentially collaborate with the PCP on how we could reduce or we could stop healthcare worker infections. Oops. Sorry, I think my slides were cut. Oh. Dr. Oliva, can you please proceed with Thea or question and answer while I'm looking for my slides on healthcare worker
Okay,
infection?
ma'am. Thank you, Dr. Escalante. We'll move forward to our second speaker and we'll just go back to your slides after the Dr. De Guzman's talk, if that's okay. Thank you, Dr. Escalante, for that uh, very wide explanation on the importance of contact tracing and breaking the chain, especially during this pandemic. So, to discuss the experience here in the Philippines is a person from the Department of Health. She's a medical specialist for and the training officer of the Philippine Field Epidemiology Training Program of the DOH Epidemiology Bureau. She is a development manager before she was the development management officer 5 of the DOH and was a medical specialist for the DOH as well in Cagayan Valley. So doctors and participants here in the webinar, may we welcome Dr. Alithea Rabulan de Guzman to talk about the experiences of contact tracing here in the Philippines. Dr. de Guzman.
Hello, good morning.
Morning.
Thank you for the opportunity to share what the Department of Health has done. Let me just share my screen. Okay, so it has been several months since we started our battle against COVID, and I'd like to put across three major messages. The first is that the need to first detect cases so that we can initiate contact tracing. Second is the need to shift to an electronic information system so we ensure better and simultaneous sharing of information. And the third is though we have done a lot and we have done well, we need the buy-in of all sectors so that all can immediately take action and to stop this transmission. So let me go to the first message, which is contact tracing actually starts with case detection, finding our suspect, probable, and confirmed cases. I'd like to share this slide. This is actually what each has been saying that everything starts with preventing the occurrence of cases. And it is only when we start finding cases that we need to immediately, and when we start finding cases, we need to immediately respond. But everything starts with finding these suspect, probable, and confirmed cases. After finding them, we can then trace their contacts. We need to immediately isolate and quarantine them. We test them, treat them, and then we need to find a way to reintegrate them back to the community. So, what has been our challenges in detecting our cases? First are the case investigation forms. Our findings is that most of the CIFs are not actually completely filled up. So we have no date on when their illness started. We lack data on where they are staying or what's their current address or even their contact information. So we have limited information. When did this case illness start? Where was he before he started getting sick, or where has he been since he got sick? And how then will we find the case so that we can initiate contact tracing? Second is, even though case investigations are filled up, if it is not encoded in our information system, this leads to delay in case notification. Yeah? And this delay in notification also leads to the case finding out late that he or she is positive, hospitals finding out what their lab results are, and the LGU concerned identifying who are the additional or new confirmed cases in their areas. And then the third is that if a patient is not admitted in a referral or isolation facility, that makes it more difficult for our contact tracers to find them because hindi siya nasa isang lugar na pwede mo lang puntahan. We don't know if they're at home, if they have changed their address, and it makes it difficult for us to initiate contact tracing. So what we'd like to put across, these two things come together. No? We have read of the T3, the trace, test, and treat, but actually when you say tracing, you need to start finding our cases first before we can start tracing the contacts, and all of the isolation, testing, and treating will proceed. Now, let me go on a bit about the testing because a lot of questions are being posed as to who among the close contacts should be tested. This is the algorithm based on the DOH Department Memo 2020-0189 on how we manage or what are the guidelines in terms of contact tracing. Once you have identified who are the close contacts, and DocSoc has relayed to us the definition, the technical definition of who a close contact is, we first identify who are the asymptomatic and the symptomatic close contacts. Let me go first to all the close contacts who develop any sign or symptom. We need to first identify who among the symptomatic close contacts fit the case definitions relayed by DocSoc a while ago. If they fit the case definition for a suspect case, they should be tested. They should be immediately put in an isolation facility so that they will then be managed, be monitored, and they can await what will be the result after the testing. How about those who are symptomatic but did not fit the case definition? They should still undergo strict home quarantine and they should be monitored whether in the preceding days they will develop additional signs and symptoms that may eventually lead them to be reclassified as a suspect case. So that's the importance of undergoing that 14-day quarantine and for monitoring teams to check on them daily to see if there are new signs and symptoms because if the appearance of another sign or symptom, um, it may lead them to be reclassified as a suspect case, and as such, they cannot be in a home or they cannot be just quarantined in a home. They need to be immediately put in an isolation facility and they need to be tested. Okay, but again, those who did not fit the suspect case definition are only advised to undergo home quarantine, undergo monitoring, and at that time, not prioritize for laboratory confirmatory testing. What about the close contacts who had absolutely no sign or symptom? Okay, we then segregate this population into two. Are you a health worker? Meaning, are you a health worker providing direct care or attending to a COVID case? Or are you a non health worker? Let's go first to the non health workers. Asymptomatic non health workers who are close contacts are still advised to undergo the 14-day quarantine, still being monitored for development of signs or symptoms, but not prioritized for laboratory confirmatory testing. However, if you are a health worker providing direct care or attending to a COVID case, we need to do the healthcare assessment that Dr. Sok wants to discuss. We need to discuss the risk of exposure, and that risk of exposure is tied to their use of PPEs. So basically, you become a low risk health worker. You're a health worker with low risk exposure if you're always using PPEs. In any time that you provide direct care, if you get sample specimens, if you're doing other laboratory procedures to a case, or you were not involved in any laboratory accident, you can then be tagged as a health worker with low risk exposure. These health workers may report to work but should undergo self-reporting for the next 14 days, and they are not prioritized for now for laboratory confirmatory testing. However, if you're a health worker with high risk exposure, meaning at any time you weren't always wearing your PPE, or if even at one time you were involved in a laboratory accident, even if you are asymptomatic, you should undergo the 14-day strict home quarantine and you should undergo confirmatory testing. Now the question is, why is it that there will be contacts who needs to be tested and those that will not be tested? um, as our undersecretary has been saying, if our testing capacity allows, we would like all of these close contacts to be tested. However, until we reach that testing capacity, we have to prioritize who among the close contacts will be tested. Okay. The second point I'd like to put across is the need to shift from a paper-based to an electronic information system. Okay. This is the current case investigation form for the coronavirus disease, and it is quite a long case investigation form. And what we observed is that oftentimes the CIF is actually self-administered. So I've actually gone through it several times. So what the person will do is, okay, Dr. this is the CIF. Please jot down your responses. So if no one monitors whoever is filling up the form or the patient filling up the form, it's possible that he or she will not completely fill up the form. Also, our old CIF, the first CIF for COVID, actually asked for only one kind of address. And we are very used to putting in our permanent address rather than our current address. So for example, ako ulit, I'm actually from Cavite, but my current address is here in Manila. Pero parang ingrained kasi sa atin is when a person asks for your address, you put in your permanent home address. So by the time they find me, they are report me as a confirmed case. Actually, I'm not in Cavite. I'm actually here in Manila. Third is the illegible handwriting. So tayo were very guilty of this. So ang hirap no for someone who is encoding thousands of CIF trying to decode what is being written down. This really could lead to incorrectly encoded information. And because of the bulk, think of the CIF being received by our hospitals, by our laboratories, few really check whether they have completely filled up or if the information inputted there is correct. The most important information we require, aside from the name, is what's your address? What are your contact details so that when the results are out, we can contact you? When was your onset of illness? No? So those information na pinakamahalaga are actually the most often not filled up information, which as I have mentioned, had led us to the delay in finding or locating these cases once your laboratory results are out. And lastly, there are very few health facilities, and I will include laboratory facilities who have dedicated staff who will encode this. So actually, nakatambak lang siya. No? Kung wala kang encoder, magpa-pile up lang ang CIF, or when they have time, they will email the CIF to our regional epidemiology and surveillance units. But if they don't have staff who will do this, it's possible that all of these information are left in the paper but not really encoded or shared to those who need to find or to get this information. So, what has been the bottlenecks? I've mentioned a few of them already. So, when a patient gets sick, okay, they seek consult with a health provider, and usually they have a okay. So, for a while, sorry. I'm sorry. Wait. I guess maingay daw. I'll need to find another place for a while. Just give me a few minutes. I'm going to Dr. Socks. Sorry, for a while. Apologies. Thank you, Doc Sok, for providing the okay. Sorry. Let me continue. I apologize. So I'll just finish and then Doc Sok and I will be together. So again, um, let me start off with the patient again getting sick. So once a patient becomes symptomatic, they will seek consult. And as I've mentioned, more often than not, that CIF is self-administered. Actually, the laboratory requests for a different form, which will have to be filled up. So this pertains to the laboratory data that has to be submitted to our laboratory facilities. And a lot of the time, these are hard copies. Then, with the CAF and the lab request form, these are sent to our SNLs, to our reference laboratories or private laboratories. Before then, these forms are shared to EB or to the RESU. And finally, when the results get out, that's only the time that we initiate contact tracing because we identify that this case is now a confirmed case. I'm showing you this is based on average. It takes 2 days for a patient to see consult, another 2 days for a specimen to reach its laboratory. It takes an average of 7 days for information for the results to be released from the laboratory to the epidemiology bureau. And if it is paper based, it takes another 2 days from EB to RESU to LGU uh, for the data to reach the LGU and they find out that they have a new confirmed case. So on average, it takes 13 days from the time a person gets sick, from the time that we initiate contact tracing. And by that time, actually tapos na po yung 14 days na dapat yung ating kaso nag-quarantine, nag-isolate na siya, yung ating contacts dapat na quarantine na siya. So basically, it's done and we have not been able to isolate our case or we have not been able to quarantine the close contacts of our case. However, what would we like to propose is a solution which is using an electronic information system. So from the time patient comes in, it is not the patient filling up the CIF. It should really be the provider, whether it's an aide, it's a nurse, it's a physician themselves. You input that already into an information system. So the EB, in cooperation with WHO and the rate technologies, has developed what they call a COVIDKAYA information system or a COVIDKAYA application. So you input that. It is you can use your phone, you can use your tablet, you can use your laptop, and immediately all of this information will be shared to the laboratory. The RESO will find out, the LGU will find out that they have this new case. It could still be a suspect case that they have already detected. And actually, at that point, the LGU can already initiate contact tracing even by identifying the suspect cases, listing who his or her contacts have been, and immediately informing these contacts to self quarantine and advise them once the results of the case's laboratory gets out. And that can take for as little as as little as 2 days. No? And ang magiging limiting factor lang nito is how soon a patient would come in to seek consult. And we are now working that all of the information that gets into COVIDKAYA application will be immediately shared to PhilHealth so that PhilHealth will have a basis. No? You can use this data as basis for reimbursements of laboratories or of even health service healthcare service provided to those admitted or to those seen in their health facilities. Okay. So this is quite a busy slide, pero gusto ko lang pong i-share that actually there's so many players when it comes to information systems. We have Tanod COVID, which is actually it's an Ateneo application, no? Para siyang self-reporting po when you get sick or if you're a close contact. We're familiar with Stay Safe, no? Where you can register. It's an SMS. It's an based na application din. But what we'd like to show is that all of the information from Tanod COVID, or if you have a telemedicine, if you have an EMR, we would like all of that to get into COVIDKAYA, which is actually an application where we input case data, we input laboratory data, and also close contact data so that we can link all of these together. And all of this information actually gets into FASTER, which is a visual dashboard which shows the number of cases, the status of cases, and even the projections, the disease projections and modeling being done by FASTER as to when our peaks will be or how our peaks will look like after several assumptions of ECQ, testing capacity, and so on. So ang parang linchpin po dito is how robust the information ang makakapasok, especially when it comes to case, close contact, and laboratory na papasok po kay COVIDKAYA because we are the source of information of FASTER in doing their disease projections and their visual dashboards. Okay, so now I've been talking about COVIDKAYA, but what about other contact tracing applications? So Apple and Google are working on several applications. They have Stay Safe. We had COVID Safe in Australia. So napakaraming applications. Even Singapore used digital contact tracing applications. So how do they work? They actually use Bluetooth technology. So several ways. It's either ikaw, biglang maa-alert ka kasi you've been in contact with a confirmed case. So, papasok ang datos ng confirmed case kay application and i-alert ka. Parang exposure alert yung tawag ni COVID safe dito na you have been in contact with a confirmed case. But they won't tell you kung sino yung confirmed case na yun. Just an info na ikaw ay naging close contact. Or sometimes they use this Bluetooth technology para sabihin, nag-warning siya, uy, you're too close to each other. You have been in proximate location to each other. It's been 15 minutes or more. So, para siyang reminder na you should physical distance. Or some use this to track where a case or a close contact has been para malaman mo saan-saan ba siya nagpunta. Ano-ano bang venues or settings yung dapat i-avoid kasi si case ay nandoon or nagpunta si close contact doon. So it really sounds nice because para kang nare-remind na and it's like an alert nga na ikaw ay naging contact or it's telling you to be mindful of physical distancing and for us public health practitioners, pwede mong itrack kung nasaan ang ating caso or close contact but there are several challenges. No? So una, though a lot of the Filipinos actually have access, hindi syempre lahat no, may access sa ganitong technology or even know how to use this technology. So yung iba kailangan naka-internet, yung iba kasi SMS-based lang po siya. No? Also the issue of accessing personal and sensitive information. I think in Stay Safe, you have to agree to provide your information. No? But yun nga, no? How careful are we? How do they protect the data that they get? No? Is this data being encrypted? What's the assurance that this will not be used for other purposes other than contact tracing? And I guess the last is how compliant are we? Example na lang if anyone has an Apple Watch na nagsasabi sa'yo, oh, you need to stand up kasi 15 minutes ka nang nakaupo. So, tayo ba as Filipinos, is it our culture to comply to these alerts na, uy, mag-physical distancing ka or lumayo ka kasi para masyado na kayo magkalapit sa isa. So, these are things that we should look into. Challenges that if we really want to go forward in using these technologies, kailangan nating i-address. And one of the most important challenges or issues that we need to address is ensuring that patient personal and sensitive information will really be protected by these applications. Okay, now I'd like to go to my last point, which is we need to start beating COVID as one. So I'd like to show you the latest data that we have, where we have tallied almost 25,000 suspect cases, 806 probable cases, and already 13,777 confirmed cases. We're registering only 3,177 recoveries, and we have 863 deaths. No? And if you look at the donut on the left side, a big percentage of these are actually mild cases, meaning meron po silang symptoms but they are not severe, they have no warning signs. There's a small percentage po na asymptomatic or actually some would like to call it pre-symptomatic kasi at the time that we found it, hindi pa po sila symptomatic and a very small slice na severe or critical po. When it comes to our epidemic curve, we try to put it into a 7-day morbidity week rather than daily. So, kung makikita nyo, nandito po sa pinakauna yung first 3 imported cases natin. And we're very happy that we have done a lot, no? Para po itong tatlo na to, hindi na kasi siya nag-surge, no? Walang naging local transmission during that time. These were the 3 Chinese from Wuhan that very good. Ang ating contact tracing really performed well. There was really good coordination. We tracked them from Region 7 to Manila. However, ito yung sinasabi nga ni Doc Sok that we have this surge. This is the local transmission. This is the surge driven by local transmission na nangyari, na nag-peak siya mid-March. we're seeing a decrease in cases, but ito rin yung sinasabi natin that we still need to do more so that hindi lang siya decrease but it's a continuous decrease of cases para po makita natin that we're not just slowing down, we have slowed it down, but we need to start stopping this transmission. Okay. So when it comes to contact tracing po, so this is as of May 18, I'd like to point out that actually contact tracing now is it's not the lead for contact tracing is DILG, but this is being done in partnership with the Department of Health. The DILG, well, the Department of Health provides technical guidance, but it is DILG who will now operationalize the conduct of contact tracing and monitor the performance of contact tracing. No? And I'd like to show that this is as of May 18. Of the 12,513 cases at that time, we have been able to trace, meaning nakita na po itong kaso na to, na-initiate na po ang contact tracing in 86% of the cases. And from these 10,756 cases that we have initiated contact tracing, we have identified and assessed more than 64,000 close contacts. And 12% of these close contacts were actually reclassified as suspect cases because they fit the case definition. And we're seeing a case-to-close contact ratio of 1:6, meaning sa bawat isang kaso, meron tayong nakitang average of 6 na close contact. So sabi ng iba, that's small. In Singapore, they're saying sa kanila it's 20. But we'll see. Remember, we are under ECQ. So I will really not expect a large case-to-close contact ratio kasi dapat habang naka-ECQ naman tayo, ang magiging close contact mo lang talaga is yung mga nakakasalamuha mo sa bahay. No? Hindi ka kasi dapat lumalabas pa at nakikisalamuha outside of your household. Okay. So, aside from the close contact, this is what I'd like to put across. No? A lot of people are talking about testing. A lot of people are talking about how we should do mass testing. Remember the first sa ating spectrum. What is very important is we need to have minimum health standards in place. We need to think first of how do we prevent the occurrence of cases para hindi na tayo pupunta doon sa box na meron na tayong dinedetect na cases, nagte-trace, nag-isolate, and nagte-test. So, everything starts with us eh. So, cough etiquette, hand hygiene, use of PPEs, we should be in masks, we should be doing physical distancing. And if strategies 1, 2, and 3 are being met, we don't even need to go to strategy 4, which is ensuring that we find cases, we isolate cases, and we trace. No? So I hope itong 1, 2, and 3 are things that each and every Filipino will take into heart kasi kung ito ginagawa natin, kung nag-physical distancing tayo, cough and etiquette and hand hygiene, we really reduce transmission by a large percentage. And again, andun pa rin yung monitor ng settings, no? Yung sarili nating bahay. No? Yung ating workplaces. So right now, there are a number of companies and workplaces allowed na mag-operate because we need the economy to restart. So we need to ensure that all of these minimum public health standards are being implemented, are being observed in all of these settings. Okay. So almost nearing my end. I'm a training officer and I love showing this to my fellows. After the first lecture in epidemiology. And at that time, my question to them was, imagine if you're there and you have 1 case of measles. Pero ngayon, my question is, paano kung ikaw to at meron diyang isang COVID-infected person? What do you do? Do you panic? Do you run in fear? Or do we get our acts together and work as one? No? So, sa tingin ko, in any pandemic or in any health event, hindi nakapagtataka when people become anxious or when people become afraid. Pero may pagkakaiba yung pagiging anxious at takot at yung setting all of these aside kasi alam mo, you need to do something and you need to respond and you can't do it alone and you need to do it together. You need to do it as a team. Okay. So, siguro ako medyo nasa edad na rin ako na ito yung mga inabutan ko. No? I've been in public health 15 years. Pero when I ask much older epidemiologists or much older public health practitioners, my parents, they've never been in a situation where we are now. No, kailan ba yung huling pandemic or kailan ba yung huling health event where we had to close down schools, where we had to enforce enhanced community quarantines. My mother was texting me last night na parang, anak, gaano pa ba to katagal? Magtatagal pa ba to? Kasi parang hindi ko na alam kung ano pang gagawin ko. No? So, sa tingin ko, ang desisyon ay nasa atin. Um, Hindi siya desisyon ng isang tao lang. It is our decision as a collective to identify ano ba yung buy-in ko at ano ba yung investment ko in responding to COVID. It can't be just the government alone. It can't be public, it can't be private. Ito ay meron tayong taya, bawat isa, no? Kasi hindi naman to para sa isang tao lang, hindi lang to para sa iyo or sa akin. Ito kasi para sa ating lahat, no? So let me end with these three messages. First, it is high time for us to start investing in disease surveillance. It is truly one of our first lines of defense. So, ang madalas kong sabihin, if there's one silver lining for us here, siguro kasi ngayon mas naririnig ko na yung sinasabi, uy, mahalaga ang surveillance. Uy, dapat mag-invest tayo sa surveillance. Kulang tayo ng disease surveillance sa mga hospital, sa ating mga ESO at SESO. We never asked for this, but maybe because this happened, we'll make large improvements in how we conduct disease surveillance in our country. Number two, we really need to shift, no? We need to to make that transition to electronic information systems. Paper-based information systems is not working. COVID proved it to us. Hindi pwedeng papel to na pinapasa from one person to another. No? Kailangan makisabay tayo. Kailangan sabayan natin na paano natin gagawing mabilis. There's no such thing as real-time information sharing, but we can make it as close to real-time information sharing. And the last is we need each and every person's personal commitment to beating this. No? Ang madalas kong sabihin, hindi lang COVID, pero ang kalusugan natin, nasa kamay naman natin, di ba? Sa kamay natin kung tayo mag-wear ng mask, nasa kamay natin kung tayo may physical distance, kung tayo ay mag-observe ng precautions. No? If kung tayo mismo hindi natin to makomit, paano natin mabibit itong pandemic na to? So it is responsibility of each person with the whole of government to support each other and to support this response. So again, thank you, and thank you to all who listened, and thank you for the opportunity to share.
Thank you, Dr. De Guzman, for that very, very insightful talk on COVID-19 contact tracing experience here in the Philippines. Before we go to the questions, maybe go back to Dr. Escalante for the few slides that she missed. There are a lot of questions, so
Yes, thank you, Dr. Raymond. This will just be maybe 5 minutes. I will just go through it. Can you see the slides?
yes, ma'am, we can see the slides.
Okay. So I just, as I mentioned, I just really wanted to give a special focus on healthcare worker infections because I know that everyone is worried. And if we are going to look at the statistics, we are among the countries in the world with with very high infections among healthcare workers. I don't know. Sorry, Dr. Raymond. Some of my slides are not really showing. So please proceed to the question and answer. I really apologize. I will come back again.
No worries, ma'am. So no worries po. I think we have additional panelists here. I would like to welcome Dr. John Juliard Go. He's a technical officer of the WHO, and of course, Dr. Albert Domingo, who is a graduate of the UP College of Medicine and part of the, I think you are with the WHO, right, Albert?
Yes, sir.
Okay. Morning. So Actually, there are a lot of questions on the ethical and data privacy. I know you've answered it in the question and answer portion, but then there are a lot of really a lot of inquiries about how about the ethics and the compliance, particularly with data privacy on the contact tracing. So can you tell us what the WHO and the DOH are doing with data privacy? Because I think there are a lot of fears, particularly with using that data against the information against the person. Anybody can answer.
Data privacy.
Ano po?
Ano to? Ano daw? Sorry.
The data privacy, I think there is a question on ethics and compliance, particularly on the data privacy issues with the contact tracing. I think Dr. De Guzman mentioned it in her lecture that one of the obstacles in using contact tracing is really what the fear on ethics and compliance on the data privacy.
Dr. Raymond, this
Yes,
is
po.
Dr. This is Jojo. I think Albert has partially answered that in the question and answer
Yes,
box.
correct.
We have a Data Privacy Act, of course, that prohibits sharing of this type of information to people not authorized. And I guess the law specifically mentions that the very purpose of the data for data utilization should be primarily for acts that are public health in nature, and that there should be safeguarding of the privacy of the patients that we encounter in our practice and in public health as well. Over.
Thank you. There are also some people interested on the COVIDKAYA app that Dr. De Guzman in her lecture mentioned. Is it available here in the Philippines? Is it running already, Dr. De Guzman?
Hi. I think, wait, I need to go to the other.
And if Dr. De Guzman is listening, is the COVIDKAYA available for all the regions here in the Philippines, or is it just available here in the NCR?
Hi.
Yes.
Sorry.
Okay lang.
Yes, actually, COVIDKAYA is an application, but I would like to clarify that it is an application for public health workers, no, for agencies. It is not to be used by citizens. Kumbaga, yung mga hospital po natin ang gagamit, yung pong mga LGUs po natin ang gagamit kasi it will be used to input personal and sensitive information. We have been doing rollout training since last week. So sa ating mga regions, sa ating mga, actually this morning or this afternoon, we have a special session for all our laboratory facilities. We have already oriented some hospitals, but we really need all reporting units to start using this so that anyone who detects a suspect case or any LGU who is doing contact tracing, maipasok dito yung information. And then we need also our laboratories to input their laboratory dito para malilink natin siya doon sa mga kaso at sa mga close contact natin. Okay,
It's really for the DOH,
It's for-
if that's correct.
It's
Yeah.
for public, it's for health offices, it's for health facilities use. Hindi siya yung parang mga stay safe or COVID, tanod COVID na magsa-self-report ka. That's why we are partnering with these other contact tracing applications. So for example, ako, tanod COVID or stay safe, nag-report ako sa kanya na ako ay may sakit or ako isang close contact. What we would like is for their data to get into COVIDKAYA so that we can also identify sino itong mga close contacts na to na posibleng hindi siya nakita ng LGU or sino itong mga kaso na to, symptomatic sila, na hindi kasi sila nagpunta sa hospital or any health facility, and we get their data and then sila ay mabibigyan ng tulong or sila ay mahanap ng LGU so that they can be tested or if needed, they can be isolated in a facility.
All right. Thank you, Dr. De Guzman. To the WHO people, I think the success of contact tracing in other countries is really the use of artificial intelligence in detecting the cases. Do we have the capacity here in the Philippines, and can we do that as well here in our country?
Thank you, Dr. Raymond. I'm going to take that question. Yes, most of the countries in the region which have successfully controlled COVID-19 at the very first stage of the outbreak has employed very rigorous contact tracing. At ito rin po yung sinasabi namin, when we are looking at the other countries in Europe and in the US, the contact tracing has not been the primary intervention that was employed. In terms of capacity sa Philippines, from the WHO perspective, we think that the country has the machinery to undertake rigorous contact tracing. And there has been a lot of commitment from the national government level up to the local government levels. However, our observation is that the implementation is not consistent, and some LGUs are not particularly following up timely contact tracing, and that's why although in the previous slide of Dr. Teya, we see that there has already been an increase in the numbers of contact trace, but the delay in contact tracing needs to be addressed because otherwise we are not going to catch up with the transmission of the virus. So bottom line, we have the capacity and the system, but we need to make that system function well. A half functional system is not going to help us beat COVID-19.
All right. Thank you. Thank you, Dr. Escalante. There's a question in the Zoom here. We know that contact tracing can only be done by DOH or their deputized agencies and personnel. However, as a measure to prevent the spread of COVID in the workplace, can the human resources or the company clinic ask the COVID positive employees to give us the names of their coworkers that they came in contact with so that we can tell them to isolate or go on quarantine?
Okay, can I answer that,
Sure,
Raymond?
sure,
So,
Dr.
what I do suggest is, you're right. So very few talaga naman yung tao ng DOH or even our local government units. So we welcome the initiative. However, I would like to ask, no, ang aking advice is that they seek first the technical guidance and assistance of the local health office or the regional or central health office. Kasi hindi, let me put, how do I put it? May technical na definition tayo ng close contact, no? So that we need to identify sino ba yung close contact, at yun napakita ko ng algorithm kanina. So who should be tested amongst all of these close contacts? Who should actually be already put in isolation and not just in quarantine? Or kung halimbawa ito, nandito ko ngayon sa isang malaking kwarto, sino ba dito ang close contact at sino dito yung hindi nang fit ng ng definition ng close contact, and what do they do, no? So kung gagawin lang kasi ito ng isang private company pero hindi siya nabigyan ng guidance ni DOH ng ating local or regional health offices, posible kasing mayroon tayong ma-miss out. So seek the help, the technical assistance, and then if the local or regional or national health office is confident you can do it by yourself, then you can start advising your employees, but still report whatever close contact tracing you've done so that maipasok po natin siya at malaman natin sino po yung mga close contacts sa binabantayan, hindi lamang ng workplace pero dapat bantayin din of course ng LGU concerned, dahil whoever may have tested positive, dapat another round of close contact tracing yun na gagawin for our newly reported confirmed cases.
All right. Thank you, Dr. De Guzman.
If I may add.
Sure, Albert.
Yes. Further to what Dr. Thea said, and that's a very good point po na yung technical aspects talaga dapat coordinated. It also is consistent with the RA Republic Act 11332, yung sinasabing Notifiable Diseases Act, na actually ang authority talaga po natin is yung DOH and the local health office. So going back to the question, if you are a physician with a clinic inside your company, like an occupational health physician or a company physician, so to speak, it would be best to consult and to request for authority from your local health office or the DOH. Kasi po dun sa Republic Act, pag inauthorize ng DOH yung collection, you essentially become an agent of the DOH or of the local health office. So it's dual pronged. You coordinate po technically as highlighted by Dr. Thea, and legally when you get that authorization, then you can already proceed with the contact tracing. So importante talaga to link up with the ESU or the epidemiological surveillance unit. Over.
All right, thank you, Albert. I think there are some practical questions here in connection with going back in the workplace. There's a question here by Mary Evelyn Joy Limpasan. May we know if a private employer can ask the COVID-19 positive employee to give the names of the employees or close contacts in the workplace so that these individuals may quarantine themselves? So I think this really lies on the data privacy rules of contact tracing, or we throw them out of the window.
Raymond, I'll answer. So,
Sure.
babalikan ko yung nabanggit natin kanina, no? So, under RA 11332 and even in the AO where we declared COVID-19 as a notifiable disease, these are personal and sensitive information that actually only designated public health authorities are authorized to collect, no? So, ito yung binabanggit natin kanina that if this private employer, meron kasi siyang na-detect na COVID-19 positive employee, dapat makilink up siya either with the local epidemiology and surveillance unit or the regional DOH or the national DOH so that they can be trained on how to go about contact tracing. And then that's when DOH or the RESER or the LESU can tell them, okay, go ahead. If you find another confirmed case, you can get their names, you can advise them to go on quarantine. But always say that with a caveat that you have to inform the local epidemiology and surveillance unit or DOH na meron po kayo nahanap na confirmed cases at ito yung mga close contacts po nila. They can't do it by themselves lang.
All right, thank you, Dr. De Guzman. There are two questions from Facebook. So the first question goes, has the government done sufficient contact tracing at the onset of the pandemic? And what could explain the seeming plateau of the number of daily confirmed cases? Anybody can answer, especially Dr. De Guzman or from the WHO? I think because Dr. De Guzman showed that about 80% of the contact tracing patients were identified, and I think there are some few questions. What happened to why the 18% lag?
Yeah.
So Dr. Drew?
Dr. Raymond, I can try, of course.
Sure.
Well, we know, of course, as mentioned by Dr. Sok, that contact tracing is a very it's not an easy thing. It sounds easy when it's being presented, but there are so many factors that are to be considered. And one is the long turnaround time of the laboratory results. And Dr. Thea mentioned that's 13 days. And if we rely on doing contact tracing just among the confirmed cases, then it's really a problem, because by the time you start doing contact tracing, then infection likely has spread to a large part of the community. So that's an entry point. And I think it's a realization for all of us, including the DOH, that there has to be more rigorous contact tracing that should be done. And the suggestion that it should start even at the level of a suspect case, I think that has been seriously considered. And in many parts of the country, in many regions, as a matter of fact, they are already doing that kind of initiative, intensifying contact tracing by starting even at the level of suspect and probable cases, not just confirmed cases. There are other factors, of course, like the community support and the issue of stigma. And so there has to be the way to really generate the support of the community so they could be part of the initiative and they would cooperate with efforts of government, and communication strategies should address the issue and allay the fears of contacts and cases, that their privacy will be protected and only relevant information will be shared to others as necessary. And then, of course, the need to expand the local contact tracing teams. DOH definitely cannot do it alone. We have very capable epidemiology and surveillance officers at the regional, provincial, city, and municipal levels, but their numbers are not often enough to be able to do adequate contact tracing to all the number of cases, especially in Metro Manila. And thus, there is a need to expand contact tracing teams. And in this manner, like the DILG and the PNP has come into the picture, and they're very much willing to help. And on that regard, there is a need to orient and to train our partners on how contact training, contact tracing should be done. And as mentioned, we also need to identify settings, places, events, social gatherings that are attended by cases. And lastly, of course, we do the traditional paper-based contact tracing in most part of the country, but we are at least open to the use of technology solutions such as COVIDKAYA to enhance the way we do contact tracing in the Philippines. Over to you, Dr. Raymond.
Dr.
Dr. Go,
Raymond?
thank Sure, yes, Dr. Escalante.
Yeah, can I add to that?
Yes po.
That is a very important question, and I would really want to take that in a very straightforward manner, because this is a critical public health intervention that we really need to strengthen. I would say that we are slow. And the reason that we are here and to talk to you and talking to everybody is we need to push harder, and we really need to work harder. There has been a system that is set up by the government, but it is not used efficiently at many points. And of course, we are going to talk objectively about the system in order for us to be able to address this. First point is the disease notification, which is a very important component of any outbreak and for any epidemiological surveillance. We will not be able to undertake a good contact tracing or to identify the cases if we do not have the notification of the disease in the first place. The system has been put up in such a way that there are case investigations formed in hospitals, or what we call the DR, the disease receiving unit. However, the biggest frustration and maybe the bottleneck is that the CIFs are not being filled up adequately. And I was looking at a question in the chat and asking, why is the DOH or any authority unable to announce the sources of infection? And what the form was asking, there is the first part would be about the demographic information of the patient. The second part would be, and the third part, that's Annex C, is about the history, about where the patient have been to and the social gatherings that they have been to. And unfortunately, if we are going to look at the CIF, the case investigations form that are being collated at the national level, it's even less than 1% of the patients or the people, providing that information. And we try to go back and contact them, but we cannot do so much, spend so much time going back to each and every case and trying to understand what could have been the sources of infection in this country. And the reason why I'm taking this question is because we are also in this position to utilize this venue to really appeal to everyone to help us in the disease notification, and essentially for that information to be collected so that we could come up with a good picture where these infections are coming from, and we could inform the public, and we could also understand if there are clusters that are coming from those areas of infection. So it's being about, this conversation is about moving forward of what we are not able to do. We put it on the table so that everyone can help us, because at the end of the day, it is our collective responsibility to really cut the transmission as soon as possible that we get the patient. And if we are not going to be able to set up this system with a very short window of opportunity that we have, and that window of opportunity that I'm trying to say is that the ECQ will be lifted at the end of this month. And if people will get sicker and transmission will become thicker across the community, and we are not able to identify our sources of infection, then it's going to be very, very difficult for the public and for everyone. We don't want to see our hospitals overloaded with patients. We do not want to be counting deaths at the end of the day. So we need to have a collective effort to really understand what the system needs to be, how it's going to be implemented, and how in our in our respective roles as physicians, public health people, or even patients and the public will be able to collect the information that we need to identify the sources of infection. Thank you, Doctor.
Thank you, ma'am. Dr. De Guzman, any comments on the issues raised by Dr. Escalante?
I think no response is perfect, but what we need to do is find where we need to improve on. So sa akin, yun eh. Mahalaga alam natin kung saan tayo dapat mag-improve on. And like I've mentioned, ang isang naging challenge talaga namin is yung paghahanap ng kaso. So this is really a great venue for us to advocate. No? We are physicians here. So we need your help. Yung nabanggit nga ni Doc Sok. Ang major bottleneck really namin is how are CIFs being filled up, and how is this information being shared not just to EB but also to our resos and to our LGU. Yung isang bagay na yon, yung malaman ko lang sino tong kasong to, nasaan siya, anong onset niya, anong contact details niya, and we ensure that each and every case is actually in an isolation facility. Pag nalaman natin yun, magawa natin yun, malaking bagay na siya. No? And now, siguro may konti tayong paradigm shift. No? We used to do we still do full contact tracing among confirmed cases. Pero ngayon, ang sinasabi din natin, suspect case ka pa lang, hindi ka pa na-test, itetest ka pa lang, magsimula na tayo ng contact tracing. Alamin mo na, sino po ba ang mga naging nakasalamuhan nitong suspect case para itong lista na to, meron ka ng listahan ng mga contacts ng suspect case mo na number 1, aabisuhan mo na siya. Dr. Thea, isa ka sa mga naging contact ni Dr. Sok. Sa ngayon, suspect case pa lang siya, nag-iintay pa tayo ng laboratorio, pero ngayon pa lang, ina-advise na namin kayo, mag-self-quarantine kayo, mag-self-report po kayo kung meron kayong nararamdaman, at once lumabas ang resulta ni Dr. Sok, aabisuhan namin kayo kung ano ang susunod na gagawin niya. That way, we can already immediately advise those who may have been infected to isolate, to quarantine themselves. Tapos hindi po tayo nag-iintay nung napakita ko na halos 2 linggo bago natin hahanapin ang mga contacts sa to, at doon pa lang natin sila sasabihan na mag-quarantine sila. Tapos na po yung period kung saan dapat naka-quarantine sila. So, mahirap siya dahil bago siya, hindi naman natin po ito ginagawa. Pero kung hindi po natin babaguhin yung paraan natin ng paghahanap ng mga contacts at nandun pa rin tayo sa dati, no, yung ating original way of contact tracing, given the length of time before we identify these confirmed cases, hindi talaga natin sila nakaka-capture. So, find cases, isolate them, whether they're tested or not. No? Sobra tayong obsessed sa testing. So if you isolate these cases, you test who you're supposed to test, then we monitor them, we ensure na naka-isolate at naka-quarantine ang dapat naka-isolate and quarantine. Napakalaking bagay na siya. Thank you.
Thank you, Dr. De Guzman. Because of the limited time that we have, unfortunately, we have a lot of questions actually from the chat. We'll give you two more questions and then we'll end this webinar. Just to remind everybody that these is not just available for doctors, but there are also actually other healthcare workers who are in the line, and even lay people are watching us. So we thank you for attending this webinar. Our second to the last questions, kasi medyo po madami. The DILG has announced plans to hire contact tracers to augment the current workforce. What are the qualifications for contact tracers, and how many LGUs have been able to hire the required complement tracers for their population? Is only DOH contact tracers will do contact tracing for the entire country? I think so. Dr. De Guzman, were you able to get the question?
Yeah. So, as of I think middle of May, we have registered or counted based on the reports of the LGU around 38,000 contact tracers nationwide. Pero kung ifo-follow po natin yung recommended na isang contact tracer bawat 800 populasyon, we actually need another 95,000 no, na contact tracers. No? So, kailangan pa talaga ng dagdag na personnel to do contact tracing. But when it comes to competencies, na-mention ko nga, dalawa kasi or tatlong klase kasi si contact tracing na yung impormasyon. No? Unang impormasyon, kailangan yung marunong, yung kailangan magaling siyang mag-interview. Kasi aalamin niya saan-saan nang galing ang kaso at kung si close contact nag-match ba yung sinasabi ni case na nagkasama sila sa isang restaurant or nagkasama sila sa isang venue. So that's one. But there's another technical aspect which is the health status assessment. It's not enough na ma-interview mo at malaman mo kung ano yung travel history ng kaso or ni close contact, pero kamusta siya ngayon? Yung kanina sinasabi natin sa lahat ng close contact, who was able to fit the suspect case definition kasi sila po yung dapat una naka-isolate at ikalawa sila yung ipaprioritize for testing. And the third aspect of contact tracing is monitoring all of these close contacts daily kung nagkakaroon ba sila ng additional signs and symptoms. So, competency-wise, it is technical, but of course, no, what we'd like to see is, I think, it's not a matter of anong profession, ano yung naging degree mo, but it's the willingness to learn and yung trainability. No? That is why the DOH, actually in partnership with WHO and UP College of Nursing, we had developed several promotional and instructional videos that I hope will be used kasi it's simplified. It's just a 12-minute video on how you do contact tracing. And we also have an online course through the UP College of Nursing na Open University that they can enroll or register in so that they understand, no, self-administered siya, self-learning course siya na anyone can na pwede natin matutunan kung paano po mag-contact tracing. And even our RESUS and CESUS, they conduct either webinars or if social distancing permits, they also conduct face-to-face po para sa ating contact tracers, which ngayon it's a mix of medical and even non-medical personalities kasi we have the help of PNP and other agencies under the DILG na nagiging member ng ating contact tracing team. Thank you, Raymond.
Thank you, Dr. De Guzman. I think this last question would go to the WHO. There was a paper that came out recently from the UP Task Force and a forecast report, and it actually mentioned that there is a need for aggressive contact tracing should be the centerpiece of strategy in the public health situation now in the pandemic. So what's the difference between the aggressive contact tracing versus of what we're having right now? And can you comment on that statement? Anybody from the WHO? What is aggressive contact tracing?
Thank you so much, Dr. Raymond. When we say aggressive contact tracing is, again, as much as possible, we are going to be able to identify the cases and undertake contact tracing within 48 hours once the cases are identified. And they are to be isolated and quarantined within 72 hours. So, of course, we could not measure that how aggressive it is, but from the perspective of WHO, is as much as possible. 48 hours and 72 hours would need to be taking action. Another instance is another point is how the number of the contacts that we need to identify, or the number of cases that we need to trace. So we are looking at the ratio 1:6, 1:3. The question will always be coming like, are we able to identify all the contacts? Of course, Dr. Raymond, it's really very difficult, but from the perspective of WHO, we would like to recommend, as always, that at least 80% of all cases would need to be contact traced. So that means that the aggressiveness would at least meet those criteria that we have mentioned. So again, I was saying, and Dr. Thea is also saying, and in my previous statement, that the system is there, but it's not as efficient as 100% as we want to. But again, it's a way forward, and that's why the DOH and WHO supporting to put all this kind of refinement in the system. But it all takes the parts of the system, including the government, the hospitals, the laboratories, and the health information system to be able to work at a speed. So this is what we mean by aggressive. At the end of the day, the point that we all want to make is that we are able to isolate the infected individuals from the susceptible population and to quarantine the potentially infected individuals so that further transmission is not going to happen. Thank you so much.
Thank you. May humabol lang po na isang question before we end. Yes, Dr. Go, may sasabihin.
Just I also read a comment in the Q&A box, and also aware that healthcare workers' infection is a really very important issue in with this COVID situation we are in right now. And the request was actually for Dr. Sok to be able to share the slides. It's just actually 4 slides, Sok. Would you still like to do that? Can she still do that, Dr. Raymond?
Sige, sir. Pero if she can't, we will be making it available sa PCP website. If okay lang kay Dr.
Yeah, I think I have the slides in my file, Sok. Would you like me to share screen now? I mean, just for a few minutes.
Sige, sir. I think that's actually a request from some of the doctors here.
Yeah, so that's it. Can you see it?
Yes, sir. Pa-view slide.
Okay. Ayan, that's okay.
Okay na, sir.
Okay, Sok, over to you, Sok.
Ma'am, naka-silent.
Sok, naka-mute ka, Sok.
Sorry, can you move it to the epi curve? Okay, so just on this pause, so we would see the number of the healthcare workers that are infected from the start of the outbreak, and I think this is May 22 data. So out of the 13,400 reported COVID cases, we have 2,324 of them are healthcare workers. And that's around 17% of the total infections that are reported in this country. So as I was saying, it is high if we are going to look in terms of the proportion of infected healthcare workers in other countries. For the past few weeks, 6 weeks, in the past, our team in WHO and the DOH have been trying to investigate what could have been the issues that have led to this situation. And Jojo, could you go to the slide with circles? Okay, so what we know so far is that there were 2 points that we were very concerned. If the infections are already like a hospital transmission, then it would be very difficult to control. But in the contact tracing that were undertaken by the team in some of the hospitals that were visited, it's actually a kind of a cycle. So there are individuals or healthcare workers that were infected in the community and goes to work, and usually because at the early stages of the outbreak, hindi po tayo nagkakaroon ng point of entry interventions like looking at the temperature of individuals, even that is not like 100% reliable. And then and because also of the nature of this disease, a lot of the symptoms are really very mild. So the healthcare worker come to the hospital to work. And from there, some other individuals are infected. We do not have any evidence yet if a healthcare worker has infected a patient. However, we have evidence that there are ongoing hospital transmission from workers who are coming to the community, to the hospital. On vice versa, we also have evidence that health workers who are exposed in the hospital are carrying the infection to the community via the families. So this is a very complicated issue, but there are measures to be undertaken to stop the transmission. Joe, can you go back? Yeah, so no, the cascade, yes. The cascade. Thank you, Jojo. So contact tracing, again, will help us to understand why and how our health workers get infected. So we have some cascade of questions. The first one is the healthcare worker infected in the community? And again, looking at contact tracing, we could answer whether that is yes or no. And if we have already information that this healthcare worker might have been infected in the community, then he should be isolated and quarantined and not go to the hospital. Then the second question that we need to understand is that, is the healthcare worker infected in the hospital? Again, by contact tracing. And the next cascade of question is, if yes, if the healthcare worker is infected in the hospital, is there an ongoing transmission in the hospital? And we could, again, look at that by identifying the contacts in the hospital and potentially testing them for RT-PCR to identify if they have the infection. Once that is established, what and where is the source of infection? So is it because we are not able to do a triage and the infection is circulating? Is it coming from our infectious disease ward? So we need to undertake some more investigation where the source of infection is. And again, basically, of course, there are other studies that we could undertake, but if we do a good contact tracing and we could identify the settings where most of these healthcare workers are circulating, then we could identify the areas of the hospital that may be sources of infection. And the last question there, which is not completed, is there a breach in the infection prevention and control? And these breaches of infection prevention and control would include, for example, the lack of PPE or the not appropriate use of PPEs. So these are some of the questions that we could use to investigate the sources and the causes of healthcare infections. So WHO is trying to work with the DOH, and we have actually came up with a guideline on how to investigate the risk and as well as to identify the breaches of infection IPC measures as well as exposure of individuals. And WHO also has released a contact tracing guideline that could be undertaken at the healthcare setting. So I'm not going to go through this, but we are happy to share. Over to you. Thank you very much, Dr. Raymond.
Thank you, Dr. Escalante. For our last question, I think this is for, I think there was a question on the 18% that was not traced. Dr. De Guzman, what can a close contact do if not reached out by a contact tracer?
Well, kung alam mo na ikaw ay close contact, you immediately quarantine yourself. That's one, no? Siguro yung perception or pag ako lumalabas ngayon, I will not look at the person in front of me as someone not infected. So, dapat ang thinking natin ngayon, anyone who we come across may be potentially infected. So actually, whether you're a close contact or not, no, if you are not symptomatic, then you go out, you protect yourself. But if you're symptomatic, you should immediately self-isolate. Or kung alam mo na naging close contact ka, or if there's a possibility that you're a close contact, you self-quarantine and you report yourself to the local health office. Our local health offices would have the list of confirmed cases. I think merong isang lista dito, may isang question, may karapatan ba ang LGU na mag-announce? No. The LGUs cannot announce who are the confirmed cases in that area, even though the new Republic Act on mandatory reporting provides parang more authority to our designated public health officials to access personal and sensitive information. Yung pag-announce po ng pangalan ng sinong kaso, kesyo confirm, probable, or suspect yan. Sino ang close contact, hindi ho siya dapat gawin. But if you self-report, then you can be informed na opo, isa po kayo sa close contact. At ito, mabibigyan po tayo ng advice. No? So, babalikan ko, bakit hindi nahanap? No? Andun pa rin siya dun sa first bottleneck namin. The 18% we were not able to identify. Yung iba po dun ay mga bagong kaso na hinahanap pa po. Pero a large percentage of that is because we do not have the information of where these cases are. And that's where DOCSOC, WHO, DOH is working on. And thus the call that we really need to complete case information so that yun po ang driver Yun ang magda-drive ng contact tracing. Walang contact tracing na mangyayari kung hindi natin alam kung asaan ang mga kaso pong ito. Thank you, Doc Rim.
Thank you. Because we're running out of time, we have so many questions, but we will try to answer them in the Zoom chat. We would like to ask some parting words from our panelists. We'll try first with Dr. Domingo, and then Dr. Jojo, and then Dr. Escalante, and we'll end with Dr. De Guzman. Last words.
Yes, thank you, Sir Raymond. Just last words. So yes, we are focused on contact tracing right now. The national government's plan, yung T3 na sinasabi, test, trace, and treat, it is comprehensive. Let's not also forget that since the audience would be composed of doctors, habang nagko-contact trace tayo at nag-i-improve po yung ating efficiency, huwag tayong magugulat, maaaring dumami bigla yung kailangan ma-quarantine and isolate. So let us also work with our local governments and also our respective institutions na yung ating capacity to isolate or to quarantine, particularly through the latest COVID centers, the temporary treatment and monitoring facilities. Kasi ngayon, sinasabi underutilized. Pero pag nag-succeed ang contact tracing, dadami po talaga yung mga pasyente. And that's not necessarily bad.
Thank you, Albert. Dr. Go?
Yeah, thank you, Dr. Raymond. I guess Albert has said it, and Dr. Sock will say it as well. Addressing the issue of COVID is everybody's responsibility. Contact tracing, all of us can do our share to really make this efficient and more efficient and more effectively implemented, to be able to break the chains of transmission. So let's help each other. Let's do our part in flattening the curve and breaking the chains of transmission of COVID-19 in our country. Over to you, Dr. Raymond.
Thank you, Dr. Go. Dr. Escalante, last words po.
Thank you so much, Dr. Raymond and the PCP. I have two last words, 2 points rather. While we are discussing this very, very complicated issue of COVID-19 and contact tracing and how we are going to break the transmission and reduce the number of infections that we see, I would like to take this opportunity to put forward WHO's recognition of the frontliners, and these are the health workers, which are all of you who are trying to battle this epidemic every day in the hospitals, in your clinics, in the community. And WHO is so aware of the present danger that the COVID-19 is bringing to individuals in the front line. So at the back end, from the WHO's perspective, we have the high responsibility to support governments to strengthen their systems, to ensure that COVID-19 transmission is going to be stopped. So as at the end of the day, it's all about protecting the frontline workers, the public, and the individuals. So second point is, again, moving forward, this is really a very difficult fight that we are all in. And it is more from the perspective, again, of this panel and the WHO, that we are coming to really appeal to everyone that if there is anything that we could do to improve the system of suppressing COVID-19 or battling this epidemic, including contact tracing and our very respective responsibilities as professionals and individuals, then that is the support that we all need to work together for. So thank you so much for this opportunity, and as well as, again, this last opportunity to bring into the PCP these last 2 points, and we look forward to work with you in fighting COVID-19. So thank you so much.
Thank you, Dr. Escalante, for that wonderful words. Dr. De Guzman?
Okay, so firstly, thank you very much for the opportunity to share and to be heard what the UH has done. But ako, ang isip ko nga, though we recognize, of course, the value, no, the great sacrifice our health workers have done to be the frontliners, kung titingnan mo, dapat tayo ang frontliner, no? Yung tayo as a person, no? Kung tayo yung unang magdedepensa against getting sick, we prevent ourselves from getting sick, then hindi na tayo magkakascade, no, to becoming a case or becoming a close contact. So it all starts with us, yung sinasabi nga natin, personally committing ano yung ating investment into this COVID-19 response. So yan yung una sa isa sa pinakamalaga. Ikalawa is it's moving forward on how we improve our systems, our health capacities, no? Hindi lang ECQ ang kasagutan sa COVID-19. It's improving our disease surveillance systems, it's improving our contact tracing performance and systems. Yung nabanggit nga ni Dr. Domingo, napakahalaga ng isolation, because even if you find your cases, even if you test them, even if you find your close contacts, if you don't isolate or quarantine them, nothing will happen. So, isa siyang, kaya hindi siya hiwa-hiwalay. Magkakatagpi siya. No? Hindi natin pwedeng ito lang. Kailangan lahat to, meron tayong ginagawa. Otherwise, the whole system will fall. And nothing happens if we treat or we only invest in one aspect of this one spectrum of COVID-19 response. So again, thank you very much. And we really look forward to working with all of you again.
So thank you
Have a
very
good day.
much. Have a good day also. Thank you very much to our speakers and to our panelists, Dr. Domingo, Dr. Go, Dr. Escalante, and Dr. De Guzman for that insightful talk on the contact tracing. We've actually done ourselves proud by looking into the objectives and answering all the objectives of what is contact tracing, what is the status of contact tracing here in our country, and how we move forward with contact tracing here in our country. As mentioned by Dr. De Guzman kanina in her parting words, we really have to invest in our healthcare systems, and invest in disease surveillance as well, and improving contact tracing so we can break down the chain of transmission with that as COVID-19. So in behalf of the Philippine College of Physicians, Committee on Medical Education, and the DOH, a webinar committee. So thank you very much. I'm Dr. Raymond Oliva. I'm your moderator for today. Thank you very much to our speakers and our panelists. Have a good day, everyone. And to our Muslim brothers, happy Eid Mubarak to everybody. Thank you very much. Have a good day, everybody.